Hello, everybody, and welcome to this Facebook Live brought to you by the Lymphoma Research Foundation. My name is Joe Messeri, and I will be your host for today's discussion. Now, some of you may know that November is National Caregivers Month, and we are very fortunate today to have with us a couple of caregivers who have dealt with their own experiences in lymphoma, and they're here today to share their stories. We also have a lymphoma expert, Dr. Sarah Rutherford from Weill Cornell Medical Center, and then Marla and Ricky Briskman, who are going to be sharing their stories in dealing with lymphoma. Everyone, thank you so much for joining us today.
You're welcome. Thanks
Our
for having
pleasure.
us.
Thank you.
Absolutely. Dr. Rutherford, I want to start with you for a second here, because what does it mean for people who might not be familiar to be a lymphoma caregiver?
It's a great question, and I'm happy to be here to talk about this today. Um, as you can imagine, anyone who has a diagnosis of cancer can benefit very much from having someone with them along the journey, either in person or uh, with them, in terms of their connections otherwise. And so I think this we're going to go through this throughout the process of this interview, but I think it can be varied depending on the situation. But we'll touch on different types of lymphoma, different treatments, and what people can do as supporters to help their loved ones get through the process.
Okay. And with that, I want to bring in Marla and Ricky here. Can you describe, I understand that you are both lymphoma survivors and you were both each other's caregivers here, but my understanding is that Marla, you were diagnosed first. So I want to start with Ricky here. How did you feel about when you first found out about your wife's diagnosis?
You talking about her initial diagnosis or the
Yeah,
diagnosis to get the CAR T trial?
the initial diagnosis first. We'll get to the
Well,
CAR T in a little bit.
that was done. That was in '98, which was prior to Marla and I being involved with each other. We didn't get starting to see each other, start dating till 2001. So the initial diagnosis I wasn't privy to at the
We
time.
were privy to understand.
I understood what happened when we started dating, and she said, by the way, Ricky, I have cancer. I said, okay, it's no big deal. Let's plan dinner for this Saturday night. So it was like I accepted the fact that she had cancer, and I didn't look at it as anything different than somebody else who had, another kind of illness. Didn't affect the way that I, reacted to her or felt about her. And here we are 20 years later. We're married happily, and we've gone through a hell of a lot on both sides. So this is how we've been living for 20 years. Thank God everything is good.
And I understand. So when she did reveal her diagnosis to you, was it something that immediately became part of your mission? Were you immediately an advocate, or how did you get introduced to that?
Um, at the time we were dating, we didn't get married till 10 years after we started dating. So I have really been living with Marla through these different increments of treatments that she was going through. Our CHOP, the different medications and so forth, the relapses that she had like in 2005 and '06. I'm trying to remember the dates. So I was living with her this whole time, thinking that, what, we're going to get through this. It's just going to be a bump in the road. Whatever we have to encounter along the way, we're going to live our life, and we're just going to move on each time this happened.
It was scary.
It was scary knowing that I never, was involved with anybody who had cancer. I had a family history of my mother having breast cancer, but this type of lymphoma I was not familiar with. So I had to really, go to my basic knowledge of going online and learning about what is lymphoma, how does it progress, what is the treatment, what's the cure, what are the side effects. So these are basic things I had to live with, and each time Marla had a relapse or something or going through treatment, I'm looking online to see what this medication does for her. And thankfully that we got through each one until it got really progressively worse when it relapsed the last time. And thank God for CAR T. So here we are, both safe and well.
And you, Ricky, also went through your own diagnosis with lymphoma.
Right.
Can you tell me about when that happened? And then
Right.
Marla, how did that feel when the roles were reversed and you then became a caregiver as well?
I was diagnosed in 2016 by accident. I do a lot of long distance running, and I get a lot of epidurals in my back. The last time I had an epidural, which was in August of 16, I got a spinal headache. Not knowing what a spinal headache was, Marla rushed me to the hospital because I was in excruciating pain. And they did some tests on me. They took some pictures and they did a CT scan, and they discovered a lump in my psoas muscle and back. And they said, well, by the way, through a spinal headache, drink a glass of Coke and it'll go away. Not knowing that I should have done that, but thank God I went into the hospital to get the scan, and they showed the lump in the back. I was petrified. I'm thinking, oh my God, am I going to be experiencing and going through what Marla experienced? And I was thinking, this could be the end of the road for me. I don't know if I could recover from this. Marla, thank God, was able to get me in with Leo Gordon, who was a saint. And I started treatment in September, I believe it was September of 16, through a double dose of Rituxan and bendamustine. And I did that for 3 months. Boom, I was clean. Then I did a Rituxan maintenance for 2 years. And since 18, I've been totally clean. I get every 6 months, I do a CT scan and see Dr. Gordon. But thank God, I'm clean.
Well, thank God indeed. So, Marla, I want to turn to you for a second here, because when Ricky got his diagnosis, what went through your mind, especially when he had been there for you through all of your treatments and your entire journey, as you went into caregiver mode?
Well, I was certainly very scared for him because of where it was located. It was very difficult to find.
Mm-hmm.
The initial doctor wanted to open him up and move every single one of his organs over so they could take a biopsy. And we said, no, we're not going to do that. They did a needle biopsy. We weren't happy with the hospital because we had to go closest to our home. So we finally got to Northwestern. Anyhow, I have to be honest that I wasn't the kind of caregiver that Ricky was for me.
Yeah.
Ricky panics quickly, and he continually thought he was going to die. And I had been so lucky for all those years that I thought he's going to be fine. And I really believed that. I mean, I think that he believed that I was going to be okay, but he was very scared. I was less scared. And so it was hard to be a caregiver for him because he was very, very negative about his success rate. And I'm kind of embarrassed to admit that.
I mean, obviously, your situation is unique because both of you have gone. I mean, you went through this personally as a caregiver, but I'm curious, because of your success in dealing with the treatment and your survival, did that help in any way assuage some of his fears and concerns? Did you have to keep reassuring him?
I did have to keep reassuring him. I think it didn't matter because in his head it was like a death sentence. You know, it's a very scary thing. And everybody deals with it differently. I know that I was on watch and wait at the beginning, and a lot of people told me they could never do that they would have to have something right away. I trusted myself. I trusted my doctor. I trusted my brother, who's a physician, and I went with it. And thank goodness I was okay. So I was much more positive for Ricky than he was, and I tried to encourage him as much as I could. And honestly, I had to sometimes call his sisters, and they encouraged me to get out of the house because I didn't know what else to do for him.
Right.
Can I interject here? Because I think
Please,
this is
I was
why
just about to bring you back
so
in, Dr. Rutherford.
I think this is why I had a hard time answering the question at first that you posed, because everyone is so different, and it's hard to just say one. There isn't one size fits all. Um, you know, those of us who are caregivers, and I've been one myself too. You really have to draw on what you know of your loved one and do everything you can to support them and what is best for them. And so sometimes you may think that they want every little bit of information researched, but not everyone is like that. So you really need to, it's a time that you really need to draw together and make sure that what you're doing is what the person who's undergoing the lymphoma diagnosis and treatment, if that's indicated, what they really want. And so I think being really open, like good communication between the patient and the caregiver, is one of the most important things. And making sure that you're comfortable with the doctor. I actually know Dr. Gordon quite well myself, and I agree he's wonderful, and I'm glad that you both have been under his care.
He is a saint. He got us through. Yeah, he did.
Yes. So I think, making sure you're comfortable with the doctor and the care team is one of the most important aspects. And they can really help guide you into other sources of support. For example, Lymphoma Research Foundation has provided so much support. For example, educational programs, events like this today. I know I've had patients who have reached out to LRF and have been able to be connected with other patients who've undergone treatment for different types of lymphoma. And I actually, one other aspect of this that is difficult is that lymphoma is not just one disease, but practically 100 or even more types of diseases. So everyone's course is different, and you can hear that just based on Marla and Ricky's example, where one of them initially was diagnosed with a lymphoma type that was offered in the management strategy of watch and wait, or we also call that active surveillance, where we monitor closely but don't actually treat with any agents. And clearly that strategy worked well in her case, just as demonstrated by the fact that she has had this initial diagnosis over 20 years ago and looks amazing, and has been through a lot, but is doing very well. But then there are other diseases. For example, diffuse large B-cell lymphoma is a diagnosis that is often given chemotherapy up front, similarly to how Ricky received chemotherapy and then is often cured, and then the person never needs any more treatment, but then has to be monitored closely for many years. So the point is that we have to be flexible as caregivers and really be as attuned as possible to the patient, so that we can do what will serve them best during this process.
So then, Dr. Rutherford, let me follow up on that. With that in mind, then, what questions should a caregiver be asking a patient's healthcare team?
Great. So I actually think this is a good, very objective way that someone can be a good caregiver, is to actually, think about when you go to the doctor, they often say so many things that it's hard to keep in mind exactly what, especially if you're learning a whole new different disease that you've never even heard of. So the caregiver can take notes, for example, and then the specific questions I would say would be, one, we want to make sure the diagnosis is accurate. So that's why we sometimes advocate for people to go to get a second opinion, at least on the pathology, to make sure the diagnosis. That's the most important aspect of the lymphoma management strategy, is to ensure that the diagnosis is made properly. So Marla alluded to the fact that initially, it was recommended that Ricky undergo what sounds like an open surgical biopsy of the area that was of concern, but that ultimately the diagnosis was able to be made with a less invasive approach. So even that type, for example, I often become involved in people's care even before they have a clear-cut diagnosis, and help guide where a biopsy is even done. So that's something, procedures and other workup to be done before there's even a clear-cut strategy made for treatment, is something that the caregiver can kind of help the patient process, and talk to the healthcare team about what needs to be done. Biopsy, imaging tests, and any other sort of baseline tests, and then ensuring that the diagnosis is accurate. So you can suggest potentially to the care team getting the pathology reviewed at an academic center, National Institute of Health or somewhere like that to make sure that the diagnosis is accurate. And then from there, I think we can talk more about this as we go with regard to actual treatment.
So then I want to ask for Marla and Ricky here, how did you advocate for one another when it came to making sure that each of you were receiving the best treatment from your healthcare team?
Well, actually, I was pretty instrumental in helping Ricky figure out the best next step. As I said, we went to the hospital that was right by our home, and we were never going to stay there. But then I had an appointment with Dr. Gordon, and Ricky showed him what the CAT scan said, that he had some lymphocytes, and Dr. Gordon said it looked like it might be follicular lymphoma. He says, I will treat you if that's the case. And when we went to Northwestern, nobody knew for sure what the problem was. And we got the results from the original scan biopsy, and they had to do another biopsy at Northwestern. They still couldn't figure it out, and they did exactly what Dr. Rutherford said. They got together as a team and made a determination based on the information that they got that it was, in fact, follicular. And then Dr. Gordon had to take some time off because he had to have surgery. So we were given a different doctor. And I have to say that one of the things about Northwestern, as wonderful as they are, that once you make a commitment with one doctor, they don't let you really go to another doctor in the same field.
I didn't feel comfortable with this other doctor. I didn't feel that she was paying close attention to some of my needs. She felt a little distant.
Well, you needed a more emotional connection.
I needed a more emotional connection. And I asked Marla, is there any chance that Dr. Gordon could take me on as a patient as opposed to this other doctor?
So I really worked hard to talking to the physician's assistants and the nurse practitioner and kind of begging for Dr. Gordon to see him. And when when Dr. Gordon was back in the hospital again, he agreed to see Ricky.
Yeah, and he took me on.
Ricky, what did that mean for you in terms of your overall treatment, knowing that Marla was there advocating for you and helping you make sure you got a doctor that you were comfortable with leading your treatment?
It was a godsend. The fact that she was advocating for me to get in to see Dr. Gordon, that she knew what I was going through. I handled it a lot worse, obviously, than she did. I get more emotional. I get more worried, and so I think the fact that she was able to get me in with Dr. Gordon, which was really hard to do at the time, reassured her that I will be getting the most best help in the city. And I think it was a big burden off her shoulder, and obviously for mine, because I knew I was going to be in good hands.
And so as you were navigating this, then what were some of the biggest challenges you faced in being each other's caregivers?
Challenges.
It was not easy. That's not true. I just was needy. I was just needy.
Marla is more needy than I am. I don't have to have her waiting on me hand and foot all the time like she wanted me to be with her, which didn't bother me at all. I mean, I was there for her. Luckily, I was retired, so I didn't have to go to work. I was there for her like 24/7. What to cook, what to wear, what to put on, what medications to take, the appointments. I handled all that for her. I was everything. She didn't make a move without consulting me, talking to her doctors. Ricky, get on the phone, make sure that I'm listening to this correctly. So I was there for her and taking care of her, which I didn't think anything other than the fact that it's a woman that I love, that I would have done it for anybody that I care about and love. So it's like it came second nature to me. So I was there for her for every little thing.
Wow. Dr. Rutherford, I hear Ricky talking about managing all of that, the medication, the treatments, the doctor's appointments there. Do you have any advice for caregivers so that they can help their loved ones stay organized as they're going through this process?
I think it's a great question. And again, Ricky's making points that are indicating the reality here that, everyone is an individual and wants wants their caregiver to do different things. So it's hard for us to make, a clear cut sort of list of what a good caregiver would do. But I think one issue would be to recruit additional family members, for example. I mean, it's a lot. And that's a point I wanted to make, is that sometimes one person can't manage all of this. I mean, it's a lot that, it sounds like Ricky, both of you all have done a tremendous amount for each other. In that, I think that, if you need to have other family members or friends be involved, and that is good. I think as much as, again, there's, some patients may say they really only want their spouse or their partner or, one close person, but others may want 5 people, want a larger team to help support them. And so I think kind of having a conversation about that, first of all, about who you want to be helping that intimately. And then also really advocating or assigning sort of different tasks or responsibilities for different people, if that's what is sort of easier to manage. So, for example, the appointments, keeping track of appointments, that could be one person. Someone else could be following different aspects of the patient's care. So I think that it can be hard for this to all fall on one person, and so that to try to incorporate others if possible. And again, it just really needs to be tailored to each individual person, because it's so dependent on that. I think about my spouse when I hear you all talk, because I'm more like Marla in that I would want very hands-on approach, whereas I know my husband would probably want me to kind of give him more space. So I think, again, I keep coming back to communication between partners and getting more people involved would be ideal if possible, to help everyone get through it. It's difficult on everyone.
When you talk about the unique situations for one patient to the next, I want to go back to Ricky for a second here, because you mentioned early on in this the relapse that Marla had to deal with and the CAR T-cell therapy. So when Marla did go through the relapse, Ricky, what was your reaction then? Was there a feeling as though you thought you had come through it, and then to hear the relapse, or was this something you were prepared for before you got that news?
Yeah, each stage felt harder than the previous one, and then it was 5 years, wasn't it? 5 years from the last stage. Yeah, and then when she started getting all the lymph nodes all under her arms and her neck and so forth, I felt, my God, this is never ending. I got to do the whole thing all over again. I got to just recharge myself and go head on and do it again. I did it. I mean, I was a businessman for 40 years, so I understand business like I understand how to take care of Marla. I was able to put everything together in a certain way. I got support from my sisters, from her brother-in-law, emotional support. But they always wanted to take me out for dinner. Let's do this, do that. I got that from her and from them, and it was very supportive. But the overall taking care of Marla on a daily basis, it doesn't work for a lot of people, but it worked for me. I was able to handle it on a day-to-day basis with her. So believe me, there were times that we had major arguments, and she would, yell at me, this is not right, this is not right. I took it basically with a grain of salt, and I just walk out of the room and come back later, and everything is fine. But overall, we got along very well. I mean, it was 24/7 with each other, basically, and I'm able to separate what I was doing with her with my own time, because if you basically, as a caregiver, your most important thing to do is to take care of yourself. Otherwise, you're not going to be any good to the patient. So
was that difficult to you at first?
I'm sorry?
Was that difficult to you at first? Because I think that sometimes maybe people have a difficult time when their loved one is going through something, remembering to take that time for themselves so that they can be there.
No, because I made it a point. I made it a point to take care of myself. I had to. I had to work out every day. Otherwise, I'd be a mess. I'm a fairly observant Jew, so I do my morning prayers every morning. I'm close with my synagogue and my rabbi and able to talk with him. My sisters were main supporters. Her brother is a doctor, and I was able to talk to him. So I was getting support from all family members. She has a close knit group of friends who are there for her as well. But overall, I was able to handle it pretty good. I had to really pat myself on the back that I was able to get through all this, each stage that she had it. Unfortunately, the worst stage was going through CAR T. That was.
So let's talk about that. What were some of the unique challenges then that you faced as you were going through the CAR T cell therapy? I should say, as Marla was going through the CAR T cell therapy.
Well, the fact that she was able to get into the program was an accomplishment in itself. She wasn't really supposed to get in because she has mantle cell, and they were only doing large B cell patients, correct? Mm-hmm. I think there was only one other person that had a mantle cell.
So they were trying to get in.
Out of the 10 or 12 people that Northwestern had. Dr. Gordon was able to get her in, thank God. And then it was, you know what? He tried to explain to me the whole process, what's going to take place each step of the way, how her T cells are going to be, taken out. They're going to be sent to the Seattle. They're going to be genetically modified, then put back in her body a month later. Her immune system is really dropped low, so she's susceptible to any type of illness and diseases at the time. And then once she gets the T cells put back in, that's when the side effects start to really happen. And any side effect that they said was going to happen, Marla got. So, and it was tough. That was probably the worst time in the 20 years that we were together that I had a feeling that I don't know if she's going to get through this.
Wow.
I had a strange feeling that this may not work for Marla. It's a trial. Not knowing I didn't know much about CAR T. Very little was known at the time. Whatever they told me, right. But right. Still, it was experimental. And I was really nervous. I was really, really nervous.
So let me bring back in Dr. Rutherford here, because I'm curious, Dr. Rutherford, how does caring for a patient who's receiving CAR T differ from caring for a patient who's receiving another type of treatment?
Well, what I wanted to do first is actually give you a little bit more background on CAR T. So CAR stands for chimeric antigen receptor T cell therapy, and it's a really exciting new therapy that is now approved for diffuse large B cell lymphoma, mantle cell lymphoma, and follicular lymphoma, and likely will be approved for other types of lymphomas in the future. And it's considered an immunotherapy approach, which is a more novel strategy. So, for example, chemotherapy, the traditional type of treatment, works by killing cells that are dividing, and that's not specific just for the lymphoma cells. There are a lot of dividing cells in the body, and that's one of the reasons there's some particular side effects related to chemotherapy. But this is a way to actually get your immune system to better fight the lymphoma. And so at this point, it's not the first line therapy for any lymphoma type. Maybe it will be in the future. But basically, Ricky described some of the ways that it's done. So basically, a person's blood cells will be collected, processed in such a way that then the T cells, which are part of the immune system, will be infused back into the body and better able to fight and hopefully get rid of the lymphoma. And so that process actually takes a few weeks usually for this manufacturing to be done. It's usually there are a number of different companies that have these CAR T cell therapies. So and it's there are clinical trials that are ongoing with them, but they're also available commercially in certain circumstances in these different lymphoma types that I mentioned. So often, not always, but usually they require hospitalization to be administered. And then, like Ricky said, that there are certain side effects that are monitored for closely, and they often happen within, let's say, about a week or so of administration of this product back into the body. So when it's administered, it's given through the vein. It's basically looks sort of like a blood transfusion almost. And then it's not immediate, but say like in the days to weeks after, people can have pretty serious side effects. Again, they are very effective in many cases and are a great option. Obviously, they've worked very well in Marla's case, and I'm so thankful that she was able to get on that. It sounded like she got them through a clinical trial initially with Dr. Gordon because they were not approved at the time that she received them, but they were available through a clinical trial. But there are some unique side effects. So, for example, there's one that's called cytokine release syndrome, and this is something that it's from the standpoint of a physician, it can act like what we call sepsis, which is due to an infection. This is not due to infection, but it can cause fevers. It can cause. I think I'm not sure if my connection is working properly. I hope it is. I hope you can hear me. It is.
We hear you.
It can cause fevers. Okay, great. It can cause fevers. It can cause high heart rate. It can cause the blood pressure to be low. Sometimes people have to go into the intensive, hopefully for just, a matter of short number of days. There are some neurologic type side effects that can occur as well. Those are sort of the two big side effects that we watch out for, but there are some others such as infection risk, bleeding, and some other issues that can happen. So we have to really watch closely, and we ask that people stay nearby the hospital, for a period of time, like let's say a month or so after the infusion of the cells. And it's very important that a caregiver be basically with the patient or very near the patient in order to help monitor for these types of side effects and bring them to the hospital, and or call the doctor first if you're not sure whether you need to bring them to the hospital. But it is a very serious therapy. But like I said, that the side effects don't happen immediately, so it's really important. That there is one particular caregiver identified that really be there watching for these different side effects and toxicities. And again, the benefit, we think, in many, many cases outweighs the risks that I went over. But it's a very serious therapy, and it's something that we have to really, be watching for very closely for any problems, both on the side of the healthcare team and the caregiver and the patient.
So Dr. Rutherford, you mentioned the time commitment that it takes on the part of the caregiver in being with the patient at the hospital for CAR T cell therapy. Ricky mentioned that he was retired at the time when he was going through this, but what advice do you give caregivers when it comes to balancing their own working careers with caring for their loved one?
Right. I agree. I think it's a great question. And I think that that is really one of the reasons why we have to have if possible, a network of care team. And Ricky also mentioned that, he had some very good coping mechanisms. So I think, like he said, exercise, even if you're not, going to be going to run races every day, like just to get out and walk, read, have some other outlets, have some other, you need your own, as a caregiver, you need your own support system too, because this is really hard emotionally on everyone involved. So so as far as your question with regard to the working, work-life balance, I think you need to try to recruit more people from the family and friend network to help if you're not able to balance everything. I think, also there are ways of getting leave, like a FMLA, Family Medical Leave Act. I know I am often asked by patients and their caregivers to fill out paperwork for that, which I'm glad to do. So that's another aspect that you can ask the healthcare team about. There are often social workers and other support network at the doctor's office itself that can help guide you through some of this process. But I think it is definitely, if possible, having some additional people helping so that it doesn't all fall on one person, and that one person can continue doing what they need to do in terms of their own work and life balance
You
as well.
you mentioned that
Ideal.
spreading out those responsibilities, which obviously can help an individual caregiver there. I'm curious. We've heard the term caregiver burnout before. So what does that mean to you, Dr. Rutherford? And what are some things that caregivers can look for to know that they might be suffering from caregiver burnout and maybe help prevent it from happening before it does?
Okay. I think that, my impression of that, I'm not an expert on this topic, but I think that to me, it would be, that someone's giving so much of their own time and energy that they're sort of to their loved one who's undergoing treatment or care for lymphoma or other cancer or any disease really, is unable to really do take care of themselves in a proper way because they're giving so much energy to their loved one. So, I think if that happens, it may have some of the same type, uh, some of the same manifestations as like depression. For example, you may have hard time sleeping, you may be, losing weight or gaining weight or, having little energy, feeling very tired, but, uh, again, there's a lot of different possible symptoms, but I think the best thing to do in that situation is to try to take care of do things to take care of yourself too. So that might be talking to other family or friends. That might be actually getting access to a therapist yourself and talking through this with a therapist. That may be taking a break, taking a vacation, or taking, say, a week off from going to appointments or something like that and lining up someone else to do that. I think just this is often a long process. Like it's as has just been described with Marla. She was originally diagnosed in 1998 and this is 2021. So 24 years, like it's more like a marathon, and so you don't want to burn out in a short period of time because you need to continue being there for the person hopefully over years and years. So again, taking breaks, taking care of yourself, trying to get good sleep, eating well, like all kind of normal behaviors that you would do, healthy type behaviors. You have to remember to do that even when you're caring for someone else so that you can maintain it, over a
One of
long
the
period.
phrases that I feel like maybe has become a little bit cliche at this point, but I feel like I've heard over and over again is there's a reason they tell you to put your mask on first on an airplane before
Yeah.
helping somebody else out. And I think that, it seemingly was very obvious to Ricky, but I don't think that it is obvious for a lot of people out there who are dealing with their own situation because they become so focused on providing that care for their loved ones. I want to bring Ricky and Marla back in here for a second because I'm curious for the two of you and having gone through it before with Marla, I'm sure it was easier for Ricky the second time around, or maybe not. But what were some of the resources that helped you guys throughout your journey in navigating your treatment plans and your fight?
I think that the internet was helpful. I think that talking to the doctor was helpful. Um, Understanding what the expectations were for what Ricky was going to need specifically. For me, we were in a clinical trial, so we read this booklet of all the things that could happen. And so we were somewhat prepared for that they could happen. Of course, I have the attitude that I'm not going to get any of them. And always I got every one of them. So I don't know if you can prepare yourself to know that it's going to happen and how it's going to feel, but to know that it's a possibility for me, I just accepted it.
I think that's true. I mean, it's basically they send us a brochure, pamphlets of what the CAR-T is going to encompass, and I read through it and spent time reading it and rereading it, and going on the internet and trying to figure out what is this CAR-T going to do for Marla? Is this going to really help her? Is it going to set her back? It's a very difficult process to go through. But basically, it's You try to stay ahead of everything. You try to keep a positive attitude that she's going to get through this. It's just another bump. And trust the doctors. Trust the doctors and the PAs and the team that what she's going to go through. And Dr. Gordon always said, she's going to be fine. She's going to get through this. She's going to be fine. And I just trusted him explicitly. So it was a really something that I put my faith and trust in with this Dr. Gordon. And
I think the other thing is that he had a physician's assistant that told us it was going to be about a year, and we pretty much freaked out at that point.
yes,
We were like,
Wow.
don't tell us this now. It's like we sort of didn't want to know. But in the end, she was 100% right. It was.
if you can get past the first year, it's gonna be
But
be
it
better.
just that it was going to be hard for the first
Right,
year.
yeah.
And I was going to take a long time for me to recover. And it was pretty much a year to recover.
Yeah.
And so with that being said, where you are now, what advice would you give to other caregivers who are going through this right now?
No.
My advice would be to be kind of like what Ricky was. He was just there for me 100%. I was craving things like malteds when I was at home and cheeseburgers, things that I don't need, and cheeseburgers. I made him go out and get me food that I could eat. He was there for me 8 hours a day, and I kept telling him he should go home. But, I think that every caregiver has different needs. And for Ricky, his need was to be there with me and to be there in the morning when the doctor came in to hear everything that was going on.
Right.
Um,
I had to be there when the doctor made his rounds. I had to know from the horse's mouth, as opposed to Marla telling me what transpired in the last day or so. What's going to be expected today? What's going on with some of the side effects? I had to be there, and I was there from 8 o'clock in the morning till 5 o'clock at night, 7 days a week.
So my point is that for me, for Ricky to be the caregiver for me, that was important. For him, he kind of wanted to be, leave me alone, let me just deal with it the way I need to deal with it.
Yeah, totally different people.
Yeah.
On that.
So it really does sound like listening and understanding what your loved one really needs from you.
Yes.
It does seem like it's very much an individual basis.
I think so.
Yeah,
Yeah.
Absolutely. Right.
Yeah. And
And
Dr.
I
Rutherford,
also,
obviously
too,
you mentioned, oh, I'm sorry.
what I was going to say is, as the caregiver, I want to advocate that the caregiver gives what they can, but if they can't do, it may not always line up exactly that the caregiver can give exactly what what the patient wants. And so that's why we sometimes need to have more than one caregiver, because, even though it may be that, say a new patient I meet tomorrow who is going to be getting CAR T cell, maybe they want to be there 8 hours or 10 hours a day, but maybe they can't be. Maybe they have young children. Maybe they have a work responsibility. And so, one good aspect of the pandemic has been that we've started to do so many things virtually. So, for example, I've had virtual discussions with patients and families where we could, like, even if the family member isn't in the hospital, I've been able to get the family member on the line, and all of us can do like a Zoom call together and talk, which has made it easier for everyone to communicate well. Just again, like this is all about balancing and knowing that someone's probably going to be living with this type of situation for a long time. So I'm trying to sort of avoid for a caregiver to feel guilty if they can't give exactly every all the amount of time that they really want to give. That there are other ways, there are other strategies that we can use, and and getting more support for the patient, so that it doesn't always fall on one person if it's not feasible for them to deliver that.
So with that being said, Dr. Rutherford, are there a few resources that you can point people to if they need support as caregivers?
Yeah, so I agree. Like I've already mentioned the LRF that that I've worked really closely with for many years now, and have found there are a number of resources that they can provide. I think that the healthcare team can help identify, for example, volunteers, other survivors of lymphoma. There are lots of sort of different layers of support. One thing I'm thinking of is that we have some patients who get art therapy or other types of therapy, talk therapy, et cetera, to try to help them deal with this. So again, I think, getting as much resources as possible to help both the patient and the caregiver navigate through a difficult process is helpful.
Well, Dr. Rutherford, I want to thank you for your time. Ricky and Marla, I want to thank you so much for sharing your personal stories with us. And to all the caregivers out there, I want you to know that there are resources out there like the Lymphoma Research Foundation where you can go for help. You can always visit lymphoma.org, or you can call the LRF helpline, which is 800-500-9976. Please be sure to like our page here on Facebook and subscribe so you can get updates on conversations like this. And as always, please do utilize the Lymphoma Research Foundation as a resource in your journey, wherever you might be. Thank you to all of today's guests, and thank you to everybody who tuned in. We'll see you next time here on Facebook Live. I'm Joe Messeri. Thanks for watching today.